Welcome to the deep dive. Today, we're strapping on a different kind of underwater breathing gear. Closed Circuit Rebreathers, or CCRs. We've gathered a fascinating collection of information, mainly from these expert chapters in hyperbaric medicine practice.
Yes, some really dense stuff in there.
Totally. And our mission really is to unpack how these clever systems work and, why they matter if you're interested in diving.
Exactly. Think of it as understanding how divers can breathe underwater in this really self-contained, almost secret way.
Secret.
We'll trace the evolution, the history of this tech, and crucially highlight both the incredible potential and the very specific challenges and risks that come along for the ride.
Right. So forget that usual image of bubbles streaming up to the surface.
Yeah, completely different.
We're diving deep into the mechanics of breathing at depth within these closed loops. And our aim is to surface with a clear, concise understanding of CCRs for you, the listener.
Sounds good.
Okay, let's get right to it. What fundamentally is a closed-circuit rebreather?
Okay, imagine a diver exhaling.
Right.
But instead of the bubbles floating away, that breath gets captured.
Captured.
Yeah, and then it's scrubbed clean of the carbon dioxide, that's the waste gas, and then it has the used-up oxygen replaced. So it's this continuous cycle, a closed loop, where the diver basically breathes the same gas over and over again, hence the name closed circuit.
Okay, so the big difference from standard scuba, where, each exhaled breath is just vented out.
Right.
Gone.
Right, new gas every time with open circuit.
With the CCR, it's more like a carefully managed internal atmosphere that diver carries with them.
Precisely. And this idea, while it's super refined for modern diving, it isn't actually as new as you might think.
Oh, really?
Yeah, our sources trace its origins way back to 17th century submarine designs.
Wow, 17th century. Talk about ahead of their time.
Seriously.
Huh?
But the first commercially viable unit for actual diving came much later, 1878, thanks to a guy named Henry Fluess.
1878. That's still a surprisingly long time ago. So not exactly a flash-in-the-pan invention then.
Not at all.
When did this technology really start to, take hold?
Well, the early 20th century saw some significant progress. Draeger in Germany started mass production around 1912.
Okay.
And these early rebreathers, they were quickly recognized for their military potential, adopted by the Italian and German navies, sort of between the world wars.
Makes sense for military use. Stealthy.
Exactly. But there was this parallel and absolutely crucial development happening in the U.S. with a medical student named Christian J. Lambertsen back in 1939.
Lambert. Yeah, that name rings a bell in diving. What was his pivotal contribution?
So he was a dedicated swimmer and diver, right? And he was experimenting with a closed breathing circuit using 100% oxygen.
Pure oxygen.
Yeah. But he soon hit a wall with a buildup of carbon dioxide. Just couldn't get rid of it.
The CO2 problem.
Right. So inspired by anesthesia equipment he'd seen, he introduced a chemical to absorb that CO2, what we now call a scrubber.
The scrubber, okay.
And he added one-way valves to make the whole thing work effectively. This creation, this recirculating loop, it was a total game changer.
How so?
It meant divers could carry far less gas, but stay underwater much, much longer. And crucially, without any telltale bubbles.
The no bubble aspect again. That must have been huge for military operations. Stealth.
Absolutely critical. It was developed during World War II, his invention. Patented in 1944 as the Lambertsen Amphibious Respiratory Unit, or LARU.
LRU.
Yeah, and it became standard issue for the early U.S. Navy underwater demolition teams. The forerunners of today's SEALs.
Wow.
And here's a fun fact for you. That very LARU, it was renamed SUB in 1952.
No way. So the acronym SCUBA actually comes from a rebreather design.
That's right.
That's not something most people know, I bet. Crazy. Now, you mentioned these early designs used 100% oxygen. What were the limitations there?
The big one was depth. Simple as that. Breathing pure oxygen at depth under pressure carries a really significant and dangerous risk of oxygen toxicity.
Right. O2.
Yeah.
Toxins.
Exactly. So these early units were limited to pretty shallow dives, less than 30 feet or so.
Okay.
The real breakthrough for going deeper came with adding a gas diluent.
Diluent, like thinning it out.
Yeah, basically. Think of it like adding another gas like air or nitrogen or later helium to the pure oxygen to reduce its overall concentration, its partial pressure.
Ah, okay.
This allowed divers to maintain a safe, constant level of oxygen regardless of the pressure or depth they were at.
So you control the oxygen percentage effectively.
Precisely. And this is where CCRs inherently become much more efficient than standard scuba. You need way less gas overall, and you also absorb less inert gas, like nitrogen, into your body.
But I guess with this added capability comes more complexity, doesn't it?
Exactly right. Suddenly, you're not just breathing. You're actively managing the levels of both oxygen and carbon dioxide. Very precisely.
And if that goes wrong?
Well, if these aren't controlled correctly, divers face what the experts call the 3 H's.
The 3 H's sounds ominous.
They are. It's hypoxia, too little oxygen, hyperoxia, too much oxygen,
Yeah.
and hypercarbia, way too much carbon dioxide.
Hypoxia, hyperoxia, hypercarbia. Okay, the cardinal dangers of CCR diving, it sounds like.
Pretty much, yeah.
So how did the technology evolve to help divers manage these risks?
Well, the next major leap was the development of electronically controlled CCRs, or ECCRs.
Computers get involved.
Yep. The first operational one was Stark's Electrolung in 1968. Then, in '69, came the BioMarine 1000, which was a real step forward because it incorporated galvanic oxygen sensors.
Oxygen sensors, okay.
And this was tech initially developed for NASA, actually.
Space technology.
Right, making its way underwater. This design eventually became the U.S. Navy's Mark 15 rebreather, which is still renowned for its performance on really deep dives.
Amazing. What about for the rest of us? The recreational and technical diving worlds? When did CCRs become more accessible?
Well, Draeger offered some consumer semi-closed units earlier on, but the real modern era of electronically controlled CCRs for, a wider audience, that really kicked off around 1999.
Okay, turn of the millennium.
Yeah, with the Ambient Pressure Diving Inspiration Classic, the INSPA.
The Inspiration. Heard of that one.
Yeah, that ECCR arguably brought the technology into the mainstream. It's now one of the most commonly used models worldwide.
Okay, so we've got the history, the core principles. Let's talk about the why. What are the main advantages of choosing a CCR over good old open circuit scuba?
The benefits are pretty significant, especially for certain kinds of diving. Number one advantage, gas efficiency. Superior gas efficiency.
Right, using less gas.
Dramatically less.
Yeah.
Because you're recycling your breath, you use way, way less gas, particularly at greater depths where open circuit divers are just chewing through huge volumes of compressed air.
Yeah, I can imagine.
Think about it. You could potentially explore for hours on the same small cylinders that an open circuit diver might burn through in like 20 minutes at depth.
That's a massive game changer for longer dives or, deep exploration. What else is a big plus?
Minimal bubble production. That's another major benefit.
The silent running aspect.
Exactly.
Yeah.
CCRs only release bubbles in very specific situations, maybe during ascent if the loop gets overpressurized or if you clear your mask, that kind of thing.
Okay.
So for wildlife encounters, underwater photography, or minimizing disturbance in fragile environments like caves or wrecks, this silence is invaluable.
Yeah, imagine getting closer to marine life without that constant stream of noisy bubbles.
Totally changes the interaction. Underwater photographers absolutely love that stealth mode.
I bet.
Also, CCRs deliver breathing gas that is warm and humidify.
Oh, that sounds nice. Unlike that cold, dry air from a tank.
Exactly. The recycled gas in a CCR actually retains moisture and warmth from the diver's own breath. It makes for a much more comfortable experience, especially on long dives. And it can be better for people with reactive airways, too.
That sounds way more pleasant, just physiologically. What about coming back up? Decompression?
Yeah, CCRs offer the potential for much more efficient decompression schedules.
How does that work?
Because they let you maintain a really stable, optimized level of oxygen throughout the dive and minimize the buildup of inert gases like nitrogen or helium.
Right.
You can then fine-tune your gas mixtures during ascent to off-gas to release those inert gases from your tissues more effectively than you typically can with the fixed gas mixtures of open circuit diving.
So potentially shorter and maybe safer decompression stops.
In many cases, yes. Provided, of course, everything is planned meticulously and executed correctly. It's not automatic.
Right. Operator skill is key.
Always. Now, all this sophisticated functionality, it depends on a number of key components working together. Should we take a look under the hood of a typical CCR?
Yeah, let's do it. What are the essential parts of this underwater life support system?
Okay, the heart of it is the loop. That's the entire pathway the breathing gas takes as it circulates.
So loop. Got it.
This loop is interrupted by the dive surface valve, or DSV. Think of it like the mouthpiece, but with the built-in on-off switch.
So you can seal the loop off.
Exactly. Prevents water getting in when it's out of your mouth. Then you have the counter lungs, or CLs.
Counter lungs?
Yeah, these are basically flexible bags, like bellows, that provide the necessary volume to hold the inhaled and exhaled breath within the loop. They expand and contract as you breathe.
Okay. And we often see those mounted in different places on divers, right? Like on the back or over the shoulders. Does that position matter?
It does, yeah. Where they're mounted can definitely influence how easy it is to breathe the work of breathing, depending on the diver's position in the water, their trim. We can get into the physics of that a bit later.
Okay, interesting. What else?
Next, you've got the gas cylinders themselves. You'll have a diluent cylinder and an oxygen cylinder connected to the system.
Diluent and oxygen.
Right. The diluent gas, which could be regular air or nitrox or maybe a helium mix like trimix, its job is to dilute the pure oxygen being added.
To get that right partial pressure you mentioned.
Exactly. To keep the oxygen level safe at different depths. Divers can also do what's called a diluent flush, flooding the loop with diluent for various reasons like checking oxygen sensors are reading low correctly or quickly changing their target oxygen level.
And I imagine the oxygen cylinder is pretty small compared to a standard scuba tank, given that gas efficiency we talked about.
Oh yeah, much smaller generally.
Yeah.
Now, a truly critical safety component, the oxygen sensors.
Right, the things measuring the O2.
Usually galvanic sensors. They give a continuous real-time measurement of the oxygen level, the partial pressure in the breathing loop, translating that into an electrical signal the dive computer and sometimes the diver directly can see.
So the diver always knows, or should always know, exactly how much oxygen they're breathing.
In theory, yes. But these sensors operate in a really tough environment. High humidity, high pressure. They can fail.
How can they fail?
Various ways. They can run out of juice, basically reach their current limit. They can corrode. The contacts can break. It's why modern CCRs pretty much universally use not just one, but 3 or more oxygen sensors.
Redundancy. Makes sense.
Yeah, it's like having backup gauges.
Yeah.
They use voting logic, so if one sensor disagrees with the others, the system can flag it or ignore it.
Definitely better to have backups when your life literally depends on it. What else is essential?
A dive computer, specifically designed for CCRs, is absolutely vital. It takes the oxygen readings, other gas info, depth, time, and calculates your decompression obligations in real time.
Integrating all that data.
Yep. And many CCR divers actually use multiple computers, often different makes, as another layer of safety.
More redundancy. Good plan.
Then we have the carbon dioxide scrubber. This is the container filled with that chemical absorbent.
The stuff that gets rid of the CO2.
Exactly. Most commonly, it's soda lime that's a mix of calcium hydroxide and sodium hydroxide. It chemically binds with the exhaled CO2. And this reaction actually produces heat.
Ah, you mentioned that exothermic, so the scrubber canister actually gets warm when it's working.
It does, yeah. You can often feel it. These scrubbers come in different designs. You might hear terms like radial flow, axial flow, and increasingly pre-packed cartridges.
Okay.
They're all designed to ensure the breathing gas flows through the absorbent material effectively, maximizing CO2 removal and preventing problems like channeling, where the gas finds an easy path through without getting properly scrubbed.
Channeling.
Bad news. Very bad news.
Yeah.
The whole CCR unit is typically mounted on a backplate, often metal or sometimes plastic, similar to standard technical diving setups.
Right.
Those side mount configurations, where the cylinders and sometimes the rebreather itself are worn along the diver's sides, are becoming more popular, especially for squeezing through tight spots in caves or wrecks.
Ah, streamlining.
Yep. And finally, arguably the most important single piece of safety gear.
The bailout cylinder?
Yeah, a completely independent open-circuit scuba cylinder, sometimes more than one, with its own regulator. Ready for immediate use if anything goes wrong with the main CCR, or even if the diver just feels uncomfortable and wants off the loop. Some divers even carry a second, smaller CCR as bailout.
Wow, a whole separate system just in case. That tells you something about the complexity.
It does. Preparation and redundancy are everything.
Okay, sounds like a complex but really carefully engineered piece of equipment. Now, we've touched on different types of rebreathers. Can you give us a quick rundown of the main categories?
Sure. Broadly, you've got semi-closed rebreathers, or SCRs. You can think of those as sort of gas extenders, maybe a stepping stone between open circuit and fully closed circuit.
How do they work?
They continuously inject a fixed amount of fresh breathing gas, often nitrox, into the loop, and then vent a portion of each exhaled breath, so not fully closed.
Okay, semi-closed, then the main ones we're discussing.
Then you have the closed circuit rebreathers, CCRs, which, as we've said, recycle pretty much the entire breath and rely on that CO2 scrubber.
Right.
Within the CCR category, the big distinction is how the oxygen is managed. You've got electronically controlled CCRs, ECCRs, where a computer and solenoid valve automatically maintain the target oxygen level.
The automated ones.
Then there are manual CCRs, MCCRs, where the diver manually adds oxygen as needed, often by pressing a button. Some MCCRs use a constant mass flow, or CMF, system that leaks a tiny, steady stream of oxygen into the loop, which the diver then tops up manually.
More hands-on control.
Exactly. And then you have hybrids, HCCRs, which combine both electronic control and manual addition capabilities.
Best of both worlds, maybe.
Potentially, yeah. There's the diver options. And finally, there are pure oxygen rebreathers. These are mainly used by military personnel for shallow, stealthy work. No diluent gas, just 100% O2.
And very strict depth limits, like you said before.
Absolutely. Because of that oxygen toxicity risk. They really aren't for recreational or typical technical diving.
Okay, quite a diverse range of approaches, all trying to solve that fundamental challenge of breathing underwater efficiently and, ideally, safely. Now, let's shift focus a bit to the physical demands. How do CCRs interact with the diver's body? Our sources really highlight work of breathing and static lung loading as important concepts. What do these mean for someone using a rebreather?
Right. This is crucial. Because a CCR recycles the breathing gas, the diver is the one who has to provide the energy, the muscular effort, to move that gas around the entire breathing circuit, the loop.
Ah, so the machine doesn't push the air for you.
Not usually, no. That effort the diver has to put in, that's called the work of breathing, or WOB.
Work of breathing, WOB.
Okay, and this WOB is very closely tied to something called static lung load, which is also known as transpulmonary pressure, or PTR. And both of these factors can significantly impact the potential for carbon dioxide buildup hypercarbia.
So it's not just about whether the machine itself is working correctly, but also about how much effort the diver's body physically has to exert just to breathe through it.
Exactly. Understanding WOB and static lung load is really key to understanding how a diver's body responds physiologically when using a rebreather, especially at depth.
Okay, and how does this relate to gas exchange at depth?
Well, think about breathing at the surface. Air moves pretty easily in and out of our lungs. But underwater, the increased pressure makes the gas denser, thicker.
Right, like breathing honey almost.
Kind of, yeah. And just being immersed in water changes things too. Squashing your chest slightly. All this affects how efficiently we can breathe, how well we can ventilate.
Ventilate, meaning move air in and out.
Yeah. If a diver can't effectively move enough air in and out of their lungs, they can't get rid of the CO2 they're producing. That leads to a buildup of carbon dioxide in the blood, hypercarbia.
And that can be serious.
Oh, very serious. It can impair judgment, cause confusion, lead to loss of consciousness, and even be fatal.
And our sources specifically mention mechanical problems with the CO2 scrubber as a direct cause of this hypercarbia.
Absolutely. The scrubber is the primary defense against CO2 buildup. If it's not working properly, maybe the diver isn't breathing slowly and deeply enough for the gas to have enough dwell time in the absorbent.
Dwell time, like contact time.
Exactly. Or maybe the chemicals in the scrubber are just used up, exhausted. Or perhaps the diver is working really hard and producing more CO2 than the scrubber can handle.
Over-breathing the scrubber.
Right. Any of those things mean CO2 isn't removed effectively, and hypercarbia will inevitably follow.
So following the manufacturer's guidelines for how long a scrubber canister can be used and matching it to the dive conditions and your expected effort level is absolutely critical.
Non-negotiable. Now let's break down these different factors that contribute to that effort. The work of breathing. Our material mentions things like inertance, elasticity, resistive effort, and dead space.
Okay. It said inertance isn't usually a big deal for divers.
That's generally correct, yeah. Inertance is the energy needed just to accelerate the breathing gas and move your chest wall. It really only becomes a significant factor at very high breathing rates, which aren't typical during a relaxed dive.
Okay, so we can mostly ignore inertance. What about elastic loads? Those sound more relevant.
Definitely. The main things here are, 1, how easily your lungs and chest wall can expand and contract, that's called compliance, and 2, that transpulmonary pressure, PTR, or static lung load we mentioned.
Right. How does being underwater affect compliance?
Well, when you're immersed, especially upright, gravity isn't pulling blood down to your legs as much. More blood returns to the heart and pools in the blood vessels within your lungs.
Ah, so the lungs get a bit congested.
Effectively, yeah. This makes them slightly stiffer, less compliant, harder to inflate. It also reduces some of your lung volumes, like the expiratory reserve volume, ERV. That's the extra air you can forcefully breathe out after a normal exhale.
Okay.
Divers often compensate subconsciously by trying to keep their lungs a bit more inflated, maybe exhaling more forcefully, to help keep airways open. But this increases the elastic work your breathing muscles have to do.
And this PTR, or static lung load, you said it's really central to the work of breathing on a CCR. What exactly is it and why is it so important?
Okay, PTR is basically the pressure difference between the inside of the alveoli in your lungs and the space around your lungs, the pleural space. With rebreathers, this pressure difference is largely determined by the hydrostatic pressure difference, the water pressure difference between where the counterlungs are located and the centroid of the diver's lungs, a sort of balance point in the chest.
So it depends on where the counterlungs sit relative to your chest.
Exactly. The static part refers to that fixed vertical distance, regardless of how the diver is oriented. Ideally, the static lung load should be slightly positive, making it a tiny bit easier to inhale and stay within a narrow, comfortable range, maybe around 10 to 12 centimeters of water pressure difference.
So the way the rebreather is designed and how those counterlungs are positioned on the diver is actually critical for how easy it feels to breathe.
Absolutely critical. It's a major factor in overall comfort and performance.
What happens if the static lung load isn't in that optimal range? What if it's negative, making it harder to inhale?
Studies have shown that having to work significantly harder to inhale, which corresponds to a negative static lung load, can actually predict whether a diver is likely to experience hypercarbia, CO2 buildup.
Wow, really?
Yeah. On the flip side, a slightly positive load might actually decrease the perceived effort of breathing. But a significantly negative PTR can also reduce the lung's compliance further and shrink that expiratory reserve volume, leading to narrower airways.
Narrower airways means more resistance.
Exactly. And that increased resistance becomes a much bigger problem at depth because the breathing gas itself is much denser, much thicker.
Right. Trying to breathe that thicker gas through narrower pipes takes way more effort. Now let's talk about those resistive loads. You mentioned external resistance and internal resistance. External is the rebreather itself.
Correct. External resistance is essentially the friction the breathing gas encounters as it flows through all the plumbing of the rebreather, the hoses, the check valves, the scrubber material, the counterlungs themselves. This is often called the external work of breathing, EWOB, and it's directly influenced by that static lung load we just discussed.
Okay. And internal resistance, that's mostly due to how dense the gas is.
That's the primary factor, yes. Gas density depends on the specific mix of gases being used, air, nitrox, trimix, and crucially, the ambient pressure, which increases directly with depth.
Makes sense.
Higher gas density causes the airflow, especially the smaller airways deep in the lungs, to become more turbulent instead of smooth or laminar.
Turbulent flow. Harder work.
Much harder work. This turbulence increases resistance and can lead to measurable reductions in lung function. Things like your FEV1 FVC ratio, how much air you can force out quickly, your maximum voluntary ventilation, MVV, basically how much air you can breathe per minute if you really try, and your peak expiratory flow rate, how fast you can exhale. Get this. At a depth of 4 atmospheres absolute, so about 100 feet or 30 meters, a diver's MVV can be cut in half compared to what it is at the surface.
Half? That's a huge reduction in breathing capacity.
It is. And increased gas density also slows down the rate at which oxygen and CO2 can diffuse across the lung tissues into and out of the blood. It just takes longer for the gas molecules to get where they need to go.
So at depth, it's physically harder for oxygen to get in and for carbon dioxide to get out, simply because the gas is thicker and harder to move around efficiently.
Precisely. And if the diver starts exerting themselves physically at depth, this whole situation gets much, much worse. Exercise significantly increases the likelihood of CO2 retention when breathing dense gas.
Even with helium in the mix, doesn't that help?
Helium definitely helps reduce the density compared to breathing nitrogen or air at the same depth, which is why it's essential for very deep diving. But even a helium-based mix still gets significantly denser under pressure. The density will always be higher at depth than at the surface.
Okay. What about the last factor mentioned, dead space? How does that play into the effort of breathing in CO2?
Right, dead space. Anatomical dead space, that's the volume in your mouth, throat, trachea, the larger airways where no real gas exchange happens, doesn't change much with depth itself.
Okay.
But if a diver starts breathing more rapidly, maybe due to exertion or anxiety, but doesn't take correspondingly deeper breaths, so their tidal volume, the amount of air in each breath, decreases.
Shallow, rapid breathing.
Exactly.
Yeah.
Then a larger proportion of each small breath is just moving in and out of that dead space without ever reaching the alveoli where the gas exchange actually occurs.
Ah, so less useful ventilation.
Precisely. Less CO2 gets expelled with each breath, leading towards hypercarbia. The combination of increased gas density making ventilation harder and a higher ratio of dead space volume to tidal volume, VDVT, is a really significant predictor of carbon dioxide buildup at depth.
It sounds like a really intricate and potentially fragile balance between the rebreather's design, the diver's own physiology, their breathing pattern, their exertion level, and the extreme environment they're in.
That sums it up perfectly. It's a complex interplay.
Our sources include a case study, a fatality unfortunately, at a very deep depth that seems to illustrate many of these points starkly. Can you tell us about that?
Yes, it was a truly tragic incident involving a highly experienced technical diver. He was attempting a record-breaking cave dive in South Africa, aiming for a depth of 264 meters.
Wow, that's incredibly deep. Over 860 feet.
Staggeringly deep. While the exact cause of death couldn't be definitively proven post-mortem, the investigation uncovered several critical contributing factors. Crucially, the soda-lime scrubber in his rebreather was found to have been improperly assembled.
Oh no.
Which raises a very strong suspicion of CO2 breakthrough, the scrubber failing to remove the CO2 effectively.
So hypercarbia was likely involved.
Highly likely. There were also audio recordings recovered, made by the diver himself during the dives. They indicated that he was aware of elevated carbon dioxide levels, he mentioned symptoms, and he actually attempted to flush his breathing loop with fresh diluent gas.
He knew something was wrong.
He did. But the extreme depth itself played a critical role here. The incredibly high gas density at 264 meters would have drastically increased the work of breathing.
Making it hard just to move the gas.
Extremely hard. And it likely led to what's called effort-independent expiratory flow.
Effort-independent, what does that mean?
It means that even if you try to exhale harder, you can't actually increase the flow rate out of your lungs. The small airways collapse under the external pressure and the internal resistance, effectively limiting how fast you can get the gas out, no matter how much effort you put in.
Like hitting a wall when you try to breathe out.
Exactly.
Yeah.
And some researchers suggest that at such extreme depths, it's even possible to develop effort-independent inspiratory flow as well.
Wow, restricting breathing both in and out, that sounds really serious.
It is. At those extreme pressures and gas densities, the diver's own larynx and other soft tissues in the upper airway can act like flow restrictors or valves, especially when trying to inhale forcefully against that dense gas.
So what's the likely scenario that happened?
The most plausible scenario is a dangerous downward spiral. The increased work of breathing leads to more CO2 production and retention.
Right.
The rounding CO2 levels cause mental confusion, impaired judgment, maybe disorientation. This makes it harder to troubleshoot the problem or even just breathe effectively, leading to further CO2 buildup, eventual incapacitation, respiratory failure, and ultimately death.
What a terrible cascade of events.
This case tragically demonstrates that even with sophisticated rebreather technology and a highly skilled, experienced diver, the extreme physiological challenges imposed by these depths, especially when combined with potential equipment issues like a compromised scrubber, can simply become overwhelming.
A very stark reminder of the inherent risks involved in pushing the absolute limits of human underwater exploration. So, to quickly summarize the key points about work of breathing and hypercarbia in CCR diving, what should our listeners really take away?
I think the crucial takeaways are that work of breathing, how much effort your lungs have to exert, along with the static lung load created by the rebreather's design and positioning, and the overall resistance to airflow. These are all incredibly important factors. They matter in both the design and the safe use of CCRs.
Okay.
Insufficient ventilation, not moving enough gas effectively, and the resulting buildup of carbon dioxide hypercarbia are potentially fatal risks. Remember, the external factors are things like the rebreather circuit design, how the counterlungs fit, the scrubber performance. The internal factors are primarily the increased density of the breathing gas at depth and the amount of dead space relative to each breath.
And helium helps, but doesn't eliminate the density issue.
Right. It mitigates it, but gas density still increases significantly with depth. Ultimately, particularly at extreme depths, that combination of high gas density, Potential airway narrowing or collapse and effort-independent flow makes elevated CO2 levels in hypercapnia almost inevitable if exertion is high or ventilation isn't managed perfectly.
Okay, a complex challenge. Now, we touched on hypoxia and hyperoxia earlier, along with hypercarbia. Let's really dive into these three H's now and the specific dangers they present, particularly for CCR divers.
Absolutely. It's vital to understand that our bodies operate within very narrow physiological ranges for both oxygen and carbon dioxide levels. Going too far outside these normal levels can have severe consequences, and CCR divers, because they're managing this closed atmosphere, face potential risks from all three. Too little O2, too much O2, and too much CO2.
Right. Let's start with hypoxia, too little oxygen. What's the technical definition there?
Generally, hypoxia in diving is defined as the partial pressure of oxygen, the PO2, in the breathing gas dropping below about 0.16 atmospheres absolute, or ATA.
0.16. Okay. Think of partial pressure as the effector amount of oxygen available to your tissues at a given depth.
Exactly. It's the concentration multiplied by the pressure.
So what are some common ways a CCR diver could accidentally end up breathing hypoxic gas?
Well, unfortunately, simple procedural errors are a big one. Forgetting to turn on the oxygen cylinder valve, for instance.
Wouldn't you notice that immediately?
Not necessarily on a CCR. Unlike open circuit, where if the tank's off, you get no gas, on a CCR, you might start the dive with enough residual oxygen in the loop from pre-breathing or from the diluent gas.
Oh.
So you feel okay initially. As you descend, the pressure increases, and the partial pressure of that limited oxygen might even rise temporarily, masking the problem.
Until you're deeper and that oxygen gets used up and isn't being replaced.
Exactly. Then the PO2 plummets rapidly. Another, maybe less common cause, is just miscalculating how much oxygen you needed for the planned dive and running out, although usually the oxygen supply itself isn't the limiting factor on total dive time.
Right, the scrubber duration is often more limiting.
Often, yeah. And of course, certain specific mechanical failures could theoretically lead to hypoxia, although it's important to note that oxygen sensors themselves typically don't fail in a way that makes them read falsely high. They usually fail low or just die.
Okay, and rapid changes in depth, can that cause hypoxia?
Yes, potentially. A very rapid ascent can cause the partial pressure of oxygen in the loop to decrease faster than the system. Whether it's electronic or manual, can add more oxygen to compensate.
So slow, controlled ascents are key.
Absolutely. Allows the system or the diver to keep pace. Another risk comes from using gas mixtures that are deliberately low in oxygen hypoxic mixes, like maybe 10% oxygen and helium for very deep dive.
Right, the diluent.
Yeah. If you accidentally breathe that mix at a shallower depth than it's designed for, the resulting partial pressure of oxygen could be dangerously low. For example, a 10% oxygen mix really shouldn't be breathed shallower than the depths where the total pressure is about 1.6 ATA to ensure you're getting at least that minimum 0.16 PO2.
Okay, that makes sense. What are the warning signs? If a diver is becoming hypoxic underwater, what might they feel or experience?
The symptoms can be quite variable person to person and even dive to dive. And they can range from subtle to, well, catastrophic.
Yeah.
They might include a weird feeling of euphoria, almost like being drunk.
Uh-oh.
Dizziness, tunnel vision where your peripheral sight closes in, tingling sensations or pins and needles, especially in the fingers and toes, maybe numbness around the lips.
Perioral numbness, yeah.
Slurred speech, difficulty articulating words, sometimes a subjective feeling of shortness of breath, even though you might actually be breathing fine.
Yeah.
And ultimately, loss of consciousness.
And it can happen fast.
That's the terrifying part. The progression from the first subtle symptoms to suddenly passing out can be incredibly rapid. In some cases, unfortunately, loss of consciousness is the very first sign. No warning.
Wow. That's a scary prospect. Okay, let's flip to the other extreme. Hyperoxia. Too much oxygen. What are the main dangers there?
The primary concern with breathing too much oxygen under pressure is central nervous system, or CNS, oxygen toxicity. The big risk there is that it can trigger seizures, convulsions underwater.
A seizure underwater. That sounds potentially fatal.
It very often is, unfortunately, usually leading to drowning. Now, there isn't a single hard and fast safe upper limit for PO2, but commonly accepted practice in technical diving is to use a target oxygen level, or set point, around 1.3 ATA during the main working part of the dive.
1.3 for the bottom phase.
And maybe going up to 1.6 ATA, but no higher, for shallower decompression stops.
Okay.
But it's crucial to understand that oxygen toxicity can still occur even below these levels, especially with long exposure times or if other factors are involved.
And it's not just the brain. It can affect the lungs, too.
Yes. There's also pulmonary oxygen toxicity. This tends to happen with more prolonged exposures to high PO2, causing inflammation and damage to lung tissue. It's similar to what can be seen in patients undergoing long hyperbaric oxygen therapy treatments. But for divers, the acute CNS effects are usually the more immediate and life-threatening concern.
Okay. And can hyperoxia happen even on relatively shallow CCR dives?
It can, yes. Although it's considered rare, there are documented cases at depths as shallow as 3 meters, around 10 feet. The risk definitely increases significantly with both increasing depth and therefore increasing PO2 for a given mix and the duration of exposure.
Do we know how common it is?
It's hard to get exact figures for the whole diving population, but one study looking at Israeli military divers using oxygen rebreathers reported an incidence of around 12%.
12% seems quite high.
It does. Similar to hypoxia, certain mechanical failures in the rebreather could lead to unintended high oxygen levels. And interestingly, a common failure mode for oxygen sensors is that they can sometimes lose accuracy or stop responding correctly at high oxygen levels, potentially giving the diver a falsely low reading when the actual PO2 is dangerously high.
So the sensors might tell you everything's fine when it's actually not. Another dangerous false sense of security.
Exactly. It underlines the need for vigilance and cross-checking, not blindly trusting the electronics.
So what are the signs? If a diver is heading towards an oxygen toxicity event, what are the warnings?
Again, it can vary, but the classic list includes things like nausea or vomiting, twitching, especially facial muscles or lips, but also limbs.
Muscle fasciculations.
Right. Disturbances in hearing, like tinnitus or ringing in the ears, or visual disturbances like tunnel vision, dizziness, vertigo, and then, of course, the most feared sign, convulsions or seizures.
That list sounds quite specific.
It is. But it's important to remember that this isn't exhaustive. One review documented over 30 different potential signs and symptoms. The critical danger, though, remains losing consciousness or having that seizure while underwater, which usually leads to losing the mouthpiece, aspiration of water, drowning, and death.
You mentioned that study of Israeli Navy divers again. What did their review find about how oxygen toxicity actually progressed in those incidents? They were shallow dives, right?
Yes, these were incidents at depths less than 7 meters, about 23 feet, using pure oxygen. They found that the most frequent symptoms experienced before the divers actually terminated the dive were things like muscle tremors or convulsions, rapid breathing, hyperventilation, difficulty maintaining a constant depth, and headache.
Okay, those seem like clear warnings.
They do. And then after the dive was aborted, the common symptoms reported included headache, sometimes loss of consciousness, confusion, general weakness, facial twitching, and limb convulsions. What was particularly significant was their finding that divers who experienced disorientation, hearing disturbances, or especially facial twitching, were much more likely to subsequently lose consciousness.
Facial twitching is a key predictor.
Seemed to be, yes. But maybe the most crucial finding from that review was that in all the cases they analyzed where loss of consciousness occurred, it was always preceded by other warning symptoms. And there was a minimum time lag of at least 5 minutes between the onset of the first symptom and the actual termination of the dive.
5 minutes? That's actually quite a long warning period.
It is, and it really challenges that common and quite scary belief that loss of consciousness is often the very first symptom of oxygen toxicity. This data suggests that might not be true, at least not always.
That's a really vital insight. It suggests that if divers are properly educated to recognize these early warning signs, the twitching, the dizziness, the breathing changes, and crucially, if they respond immediately by reducing their oxygen exposure, like switching to a lower PO2 gas or surfacing,
they might have a window of opportunity to avoid the catastrophic seizure.
Exactly. Are there any known factors that might make a particular diver more susceptible to O2 tox on a given day?
Several things have been looked at. Certain medications could potentially play a role. Pre-existing medical conditions are always a consideration in diving fitness. Some animal studies have suggested that being cold, which increases metabolic rate, and also diving in darkness might increase susceptibility. But whether this translates directly to humans isn't definitively proven. There's also some ongoing, quite interesting research looking at whether following a ketogenic diet might offer some protection against CNS oxygen toxicity.
Keto diet. How would that work?
The theory is based on the known neuroprotective and antioxidant effects of ketone bodies, which are produced during ketosis. These effects are part of why the keto diet is used to treat some forms of epilepsy. So the idea is maybe it could raise the seizure threshold for oxygen toxicity too.
Interesting parallel.
Yeah. A pilot study actually showed that divers could achieve ketosis relatively quickly using specific supplements, and it didn't seem to negatively affect their diving performance. But it's still early days for that research.
Fascinating area. Okay, let's move on to the third of the three H's, hypercarbia, the buildup of carbon dioxide. We've already talked quite a bit about the mechanical causes, like scrubber failure or high work of breathing. Are there other factors?
Yes, even if the rebreather itself is functioning perfectly, hypercarbia can still be a risk. There's some conflicting data, but some studies suggest that individuals who have a naturally lower sensitivity or responsiveness to elevated CO2 levels.
Meaning they don't feel that urge to breathe as strongly when CO2 rises.
Exactly. These individuals might, paradoxically, also be more susceptible to oxygen toxicity. Animal studies definitely show that increasing CO2 levels decreases the time it takes for O2 tox seizures to occur. And there are reports of divers seizing at supposedly safe oxygen levels, who were later found to be CO2 retainers.
So CO2 can exacerbate oxygen toxicity.
It appears so. Other factors contributing to hypercarbia can include nitrogen narcosis, especially on deeper air or nitrox dives. Narcosis can depress the brain's central respiratory drive and blunt the normal ventilatory response to rising CO2.
Makes sense.
And as we discussed with work of breathing, at very deep depths, the sheer density of the breathing gas and the turbulent flow it creates can significantly limit how effectively a diver can exhale, inevitably leading to some degree of CO2 retention, especially during exertion.
So it's this complex interplay again. What should divers be aware of in terms of hypercarbia symptoms? How does it feel?
The classic symptom is subjective dyspnea, feeling short of breath, air hunger, like you just can't get enough air.
That desperate feeling.
Yeah. Also rapid breathing, tachypnea, dizziness, and often a headache, which can sometimes be quite severe. As CO2 levels continue to climb, it can lead to impaired judgment, confusion, really poor decision-making.
Not good underwater.
Definitely not.
Yeah.
Eventually leading to incapacitation, loss of consciousness, and death if not corrected.
It sounds like the symptoms overlap a bit with hypoxia and hyperoxia too, like dizziness.
They can, which adds to the confusion sometimes. It's also really important to understand that there's significant individual variability in how well people detect rising CO2, how much CO2 they tend to retain under different conditions, and how strongly their ventilation responds.
So not everyone reacts the same way.
Not at all. Some research suggests that maybe, with specific training focusing on recognizing the subtle early signs, divers might be able to improve their personal ability to detect hypercarbia sooner.
Interesting. And hypercarbia is definitely a known factor in CCR incidents, but maybe not always with clear warnings.
Yes, it's been implicated either as a primary cause or a major contributing factor in numerous CCR-related deaths and serious incidents. However, and this is really concerning, one well-documented study by Warkander described a case where a diver experienced significant incapacitation and lost consciousness very rapidly with extremely high CO2 levels, but had apparently made no subjective complaints of dyspnea or air hunger beforehand.
Wow. No warning signs at all, despite critical CO2 levels.
Seemingly not, or at least none that were communicated. It really highlights that individual responses and tolerances to elevated CO2 can vary dramatically, and maybe even change in the same person depending on the circumstances like workload, depth, narcosis, etc.
That lack of reliable warning signs makes hypercarbia a particularly insidious risk, doesn't it?
It really does. You might not know you're in serious trouble until it's too late.
Okay. Moving beyond the three H's of gas management, our sources detail another unique and frankly pretty terrifying hazard associated specifically with CCRs, absorbent aspiration and ingestion. It's often referred to as the caustic cocktail. That sounds incredibly dangerous.
It is. This is a very serious potential risk inherent in the technology. As we discussed, CCRs use chemical absorbents usually containing strong alkaline substances like sodium hydroxide, NaOH, or sometimes lithium hydroxide, LiOH, in the CO2 scrubber.
The stuff that gets hot when it works.
Exactly. And these chemicals are highly corrosive, extremely caustic. Think oven cleaner or drain cleaner level caustic.
Yikes.
Okay.
Now, while modern rebreather designs go to great lengths to keep the scrubber canister isolated from water, there are always potential ways for water to get into the breathing loop.
How?
Maybe the diver loses the mouthpiece underwater and doesn't close the DSV fast enough. Or there could be a tear or break in one of the breathing hoses or the counter lungs.
So water gets into the loop and then into the scrubber.
If enough water gets in, yes, it can flood into the scrubber canister. When water mixes with the absorbent granules, it creates this highly alkaline caustic slurry.
the caustic cocktail.
Precisely. Now, if the diver inhales while this slurry is in the loop, the negative pressure generated during inhalation can actually suck this corrosive mixture into their airway, their trachea and lungs, and potentially down their esophagus if they swallow.
Oh, that sounds horrific. What does it do to tissues?
Contact with these highly alkaline substances, we're talking pH, often above 11.5, sometimes even above 13.5, depending on the specific absorbent.
That's extremely alkaline.
Extremely. It causes a type of severe chemical burn called liquefaction necrosis. Liquefaction necrosis.
Yeah. Unlike acid burns, which tend to cause coagulation necrosis, forming a sort of protective scab that can limit deeper damage, strong alkalis dissolve tissue. They turn it into a liquid soapy consistency, allowing the chemical to keep penetrating deeper and deeper, destroying tissue until it eventually gets diluted enough.
That sounds far more insidious and destructive than an acid burn.
It generally is, yes.
Yeah.
The extent of the tissue damage depends on several things: the concentration and pH of the alkali, how long it stays in contact with the tissue, and obviously how much of it is aspirated or ingested.
Does the body have any defenses?
Well, the gag reflex usually helps minimize the contact time in the mouth and throat. And instinctively rinsing the mouth and throat with water immediately, if possible, can help dilute it. But if the caustic slurry gets drawn down into the trachea and into the lungs...
You can't rinse your lungs out.
Exactly. It's very difficult to dilute effectively down there. Plus, reflexively spitting out the mouthpiece in panic can actually make the situation worse by allowing more water to flood the loop, potentially compromising your ability to even get back to your bailout gas supply.
A nightmare scenario. What are the immediate steps a diver should take if they suspect this has happened? If they taste that awful soapy burning sensation?
Immediate decisive action is absolutely crucial. First thing, get off the loop. Bail out immediately to your clean, uncontaminated, open-circuit gas supply.
Bail out first.
Absolutely. Then make a controlled but immediate ascent. And a dive as safely and quickly as possible. Once on the surface, the priority is thorough rinsing of the mouth and throat or pharyngeal washing with copious amounts of fresh water. Just water.
Why just water? Wouldn't an acid help neutralize it? Like vinegar?
Absolutely not. You should never try to neutralize the alkali with an acid. Remember that exothermic reaction. Mixing acid and base generates significant heat. You just add a thermal burn on top of the chemical burn, making the tissue damage much worse.
Okay, water only. Got it. What about swallowing water?
Swallowing small amounts of fresh water might help dilute any substance in the esophagus if medical help is significantly delayed, but it needs to be done judiciously. Inducing vomiting is strongly discouraged because it just re-exposes the esophagus and throat to the caustic material on the way back up.
Right.
Any diver experiencing ongoing distress, difficulty breathing or swallowing, or abdominal pain after a suspected caustic cocktail incident needs immediate emergency medical evaluation. This is a true medical emergency. It could indicate serious internal damage, potentially even perforation of the esophagus, which might require major surgery like esophageal resection and reconstruction.
And the long-term consequences if you survive the initial event can be devastating.
Extremely devastating. Probably the worst complication is tracheobronchial necrosis, or TBN, the death of tissue in the trachea and bronchi. This has incredibly high mortality rates, even with prompt diagnosis and aggressive surgical treatment. If the diagnosis is delayed, the mortality rate reported is over 80%. Without immediate access to intensive care and specialized surgery, survival is highly unlikely, near 100% mortality.
That's terrifying.
There are case reports describing esophageal necrosis, tissue death extending right through into the trachea, causing massive corrosive injuries to both the upper airway and the gastrointestinal tract. It's incredibly destructive.
So initial medical management is all about the airway.
Absolutely. Priority 1 is assessing and protecting the airway. Swelling can happen incredibly fast, and the damaged tissue can start sloughing off, blocking the airway. It might require emergency procedures like a cricothyrotomy or a tracheostomy just to secure a breathing passage.
So to sum up treatment principles.
Dilution with water irrigation. Minimize contact time. Get expert medical help immediately. Supportive care includes IV fluids, possibly steroids to reduce inflammation, antibiotics to prevent infection, and strong pain medication. Chemical neutralization is out. Blind intubation is dangerous because you can easily perforate the damaged tissue. The ultimate prognosis really depends on how deep the chemical burn penetrated the tissues. If it goes through the wall of an organ like the esophagus, causing perforation, the mortality rate is extremely high, again, over 80%.
A truly horrifying risk unique to this technology. It really underscores the importance of meticulous equipment setup, pre-dive checks, and knowing exactly what to do in that specific emergency.
Absolutely. Vigilance and preparedness are key.
Finally, let's talk about the bottom line, perhaps.
Yeah.
CCR fatalities. With the increasing popularity of CCRs, are they inherently more dangerous than traditional open-circuit scuba? What do the statistics say?
That's a really difficult question to answer definitively, partly because getting accurate statistics is challenging. We don't know the exact total number of active CCR divers or dives performed each year, which you need for reliable rate calculations. Also, accident investigations aren't always complete, and sometimes the definitive cause of a fatality remains unclear.
Okay, so the data is imperfect, but what trends have been observed?
Well, the Divers Alert Network, DAN, published annual diving reports covering 2010 to 2013. Their data showed that around 8% of global diving fatalities during that period involved CCRs. However, in the U.S., the proportion was significantly higher, closer to 30%.
30% in the U.S. seems high, given CCRs are still a smaller segment of the diving population.
It does suggest a potentially disproportionately high number, yeah. That DAN data also indicated that human factors, things like assembly errors, forgetting to open valves, using the wrong gases, checklist failures, seem to play a larger role in CCR fatalities compared to open-circuit ones.
That really emphasizes the need for that rigorous training, discipline, and adherence to checklists we keep mentioning.
Absolutely. It's less forgiving of procedural errors. Back in 2007, the American Academy of Underwater Sciences held a symposium, and they noted a rise in CCR-related deaths, which they attributed largely to the increasing popularity of the technology. Their findings also suggested that equipment trouble and buoyancy control problems were implicated more frequently in CCR deaths compared to open-circuit fatalities, where procedural errors or medical events seemed more common, with fewer true equipment failures causing the incident.
Interesting distinction.
Yeah. Similar concerns and findings were discussed at Rebreather Forum 3 in 2012, which was specifically aimed at improving rebreather safety.
So the community is aware and trying to address it.
Definitely. When you look at published case reports of CCR injuries and fatalities, you see the things we've discussed. Oxygen toxicity events, cerebral arterial gas embolism, often from rapid ascents, decompression sickness, and hypercarbia leading to respiratory failure and drowning.
The 3 H's plus DCI and AGE.
Pretty much. It does appear, based on available reports, that oxygen toxicity and deaths related to specific equipment problems or procedural errors are more frequent in CCR fatalities than in open-circuit diving fatalities. And notably, hypercarbia, while a huge concern in CCRs, is essentially not an issue as a primary cause of death in open-circuit diving.
Right, because you're constantly flushing your system with fresh gas.
Exactly. So it seems that CCRs, by enabling divers to explore more extreme environments, greater depths, longer bottom times, complex overhead environments like deep caves and wrecks, they inherently introduce exposure to new environmental hazards and more significant physiological challenges.
Challenges like severe hypercarbia or the unique risks of O2 toxicity management over long durations.
Precisely. It's also crucial to remember, as with any diving, that underlying medical problems, especially cardiac-related issues, can tragically manifest during a dive and might be underreported as simple drownings. Research into the specific effects of CCR diving, like altered breathing patterns and gas levels, on cardiac physiology is still ongoing.
So still more to learn there.
Always. But it is encouraging to see that the CCR diving community itself is heavily invested in improving safety. These dedicated symposiums, detailed incident reviews, the constant refinement of training standards, and strong calls for better, standardized pre-dive checklists, and improved education on CCR-specific rescue and resuscitation techniques. It all shows a clear commitment.
A commitment to learning from mistakes and making a complex technology as safe as it can be. Well, this has truly been a comprehensive and, at times, sobering deep dive into the world of closed-circuit rebreathers. To wrap things up, what are the key insights you'd really like our listeners to walk away with?
I think we've explored the really innovative design and the remarkable gas efficiency of CCRs, but also balanced that with a clear look at the unique set of risks. These relate directly to managing breathing gases within that closed loop, the intricacies and potential failure points of the equipment itself, and, critically, the need for a profound understanding of the physiological challenges they present.
Especially those 3 H's, hypoxia, hyperoxia, hypercarbia, and that terrifying caustic cocktail risk.
Exactly. So while CCRs offer significant advantages, opening up incredible possibilities for longer, deeper, quieter, and maybe more comfortable underwater exploration, they absolutely demand meticulous preparation, rigorous and ongoing training, deep system knowledge, and a constant vigilant awareness of these potential hazards. It's not technology for casual or complacent divers.
Indeed. It's fascinating technology, unlocking amazing opportunities, but it clearly comes with a significant responsibility for the diver to be knowledgeable, disciplined, and prepared for things that just don't happen in open circuit diving.
Well said.
So considering this complexity, the potential for both truly remarkable exploration and very serious risks, it really makes you think, doesn't it? What does this ongoing evolution of breathing technology underwater tell us about our, relentless human quest to push the boundaries of our own physiology and the boundaries of the environments we can access? Definitely some food for thought there. Thanks for joining us on this deep dive.